This is the presentation for Chapter 37, Care of Patients with Diabetes and Hypoglycemia. So diabetes mellitus is characterized by disturbances in the carbohydrate, protein, and fat metabolism. It's actually a leading cause of death in North America. Diabetes is a major risk factor for a lot of diseases and conditions such as myocardial infarctions, which is heart attacks, strokes, renal failure, peripheral vascular disease, and also blindness, among other issues or complications of diabetes. You have two forms of diabetes, type 1 and type 2 diabetes. And so let's back up a little bit. So the beta cells of the pancreas produce insulin and protein, which are then stored in the secretory granules of the cells. Increased levels of serum glucose stimulate the beta cells to release insulin into the bloodstream. Insulin can then transport the glucose and the amino acids across the cell membrane of various body cells. So type 1 diabetes, which we'll talk a little bit more in detail in a minute here, it usually occurs before age 30. But of course it could occur at any age, but typically in patients before age 30. So these patients are usually thin and require insulin and dietary management to help achieve control of their glucose levels. On the opposite end of that, type 2 diabetes mellitus, which is more common. Actually, most of the people that have diabetes, it's typically type 2 diabetes is more common. And so these individuals are obese adults, typically after the age of 40. And it's usually treated with exercise, meal planning, and anti-diabetic drugs. But it can be treated with insulin. It can be treated with insulin if need be, depending on the severity of it. But type 1 diabetics will definitely require insulin, and we'll talk about why here in a few moments. So type 1 diabetes, you may have also heard it called insulin-dependent diabetes mellitus or juvenile diabetes, because like I said, it usually occurs early in age, although it can occur at any time. But type 1 diabetes occurs when the body completely lacks insulin because the beta cells of the pancreas have been destroyed. So as a result, these patients become dependent on insulin for survival. The cause is really not certain, but a lot of experts believe that type 1 diabetes is inherited. The immune system may also play a factor in the development of type 1 diabetes. Another theory suggests a person produces antibodies against a viral infection, and after a period of time, the antibodies attack and damage the beta cells of the pancreas. So that's another theory for how it's developed. If it is uncontrolled, it can lead to diabetic ketoacidosis, which we will discuss that in some later slides, diabetic ketoacidosis. So some classic symptoms, especially the top 3 classic symptoms that you would see with diabetes mellitus: polydipsia, polyuria, and polyphagia. So you need to know what each of these terms mean. Polydipsia meaning very thirsty, polyuria meaning frequent urination, and polyphagia meaning extreme hunger are some classic symptoms that you'll see with diabetes mellitus. So when we're talking type 1, they'll also have a rapid loss of weight, some irritability, weakness, and fatigue, and maybe nausea and vomiting as well. So type 2 diabetes is, you may have seen it, called non-insulin dependent diabetes mellitus, or adult onset diabetes. And like I said, this is the most common type of diabetes that you will see in individuals. And so the experts are a little more unsure of the cellular mechanisms of what's happening with type 2 diabetes, but a couple of little things to make note. So these individuals, unlike type 1, type 2 diabetes individuals do produce a little insulin, do produce some insulin, but the issue could be of either a couple of things. Number one, the insulin that they're producing is not enough or inadequate to meet the needs of the body. So it's not enough to meet the needs of the body. Or number two, the insulin that's being produced, for some reason the tissue or the cells is not responding to the insulin that's available. So they're insulin resistant. Could be an issue. And so some of our medications that we have on some of the later slides, that's how some of the oral medications will work. They'll either help to, make the cells more receptible to receive the insulin, or stimulate the beta cells to produce more insulin or something of that nature. So like I said, the classic signs of diabetes mellitus, period, you have that polydipsia, polyuria, polyphagia. That you'll see that in type 1 and type 2. So those are some classic symptoms of just diabetes mellitus, period. But when we're talking type 2 diabetes, so like I said, these individuals are more likely to be obese. So you might see excessive weight gain. There might be a family history of diabetes mellitus. Also with individuals with diabetes, of course, especially if their blood sugars are out of control, they're going to have poor wound healing. So it's more difficult when these individuals develop wounds to try to get these wounds healed if we can't keep their blood sugars under control. They might have some blurred vision, a lot, increased fatigue, numbness, tingling in the feet, as the diabetes, starts to worsen. And so the other thing too, when we're talking about that, with the feet and them getting neuropathy, you want to always make sure you teach them to not walk around barefoot, because they can get that neuropathy. They might step on something and not realize that they've even stepped on something and develop a wound and not even know, because they can't feel it or whatnot. And so you want to teach them to always wear something on their feet, even if they're at home. Don't walk around barefoot, and to check their feet daily just to ensure, there's no cuts or sores or anything on their feet. Okay, so when we're talking about diagnosing a person for diabetes, we'll take a person's fasting plasma glucose. So that's when you check their blood sugars. You've checked their blood sugars. And so fasting, we say that's 10 hours without eating. So typically first thing in the morning, and they haven't eaten anything all night, right? So that's 10 hours with no food, and you check their blood sugar. So a fasting plasma glucose of 126 or higher. Now, if it happens one time, they wouldn't necessarily diagnose you as diabetic. But if it happened on 2 separate occasions, then you're likely to be diagnosed as being diabetic. So a fasting plasma glucose greater than 126 on 2 separate occasions would be, probably be diagnosed as diabetic. Pre-diabetes, if you have a fasting plasma glucose between 100 and 125. And so normal, they want your fasting plasma glucose to be less than 100. Your a normal fasting plasma glucose less than 100. And so your typical range would be 70 to 100. If we're under 70, then we're getting to be hypoglycemic, and we'll talk about hypoglycemia here in a few more slides. But this is from the American Diabetes Association, 70 to 100. And there's actually a table in your book on page 831, table 35.3, that outlines these numbers for you. So a normal range would be 70 to 100 when we're talking about fasting blood plasma glucose on 2 separate occasions. Now, also they check your hemoglobin A1C. So your hemoglobin A1C is your average, it tells the doctor your average blood glucose readings over the past 3 months. So it gives you an average of if you've been running high over the past 3 months, or if you've been running normal over the past 3 months. So these numbers are also in your book. You can look on that same table 35.3 on page 831 to help you with these numbers. So when we're talking diabetic, it's definitely over 6.5%. So a fasting plasma glucose, again, over 126 is considered diabetic. A hemoglobin A1C over 6.5% is diabetic. Now, a 2-hour plasma glucose, so then that means you check your blood sugar 2 hours after the person has eaten. If it's over 200, then that's likely diabetic. It shouldn't be over 200 2 hours after you've eaten. A random plasma glucose, that just means you just check it anytime. They could have eaten, at any time. It's just a random. And that one is shouldn't be over 200 either. So when we're talking blood glucose levels, you want to determine the last time that they have eaten, because obviously a fasting should be a lot less than a random or a 2-hour. Okay, so let's discuss these other numbers when we're talking about being diagnosed with diabetes. A hemoglobin A1C is when it tells your doctor what your blood glucose levels have been running for the past 3 months. So if your hemoglobin A1C has been high over the past 3 months, then I'm sorry, if your hemoglobin A1C is high, then that tells the doctor that your blood glucose levels have been running high over the past 3 months. If it's normal, then it tells your doctor that your blood glucose levels have been running normal over the past 3 months. So if we have a hemoglobin A1C that's greater than 6.5%, then that's diabetic. So when we're talking 5.7 to 6.4%, that's considered pre-diabetes. So 5.7 to 6.4% is pre-diabetes. So they want your hemoglobin A1C to be under 5.7%. Again, the fasting plasma glucose, which we just talked about, greater than 126 on 2 separate occasions, will be considered diabetic. And so that's, you haven't eaten for 10 hours when we're talking fasting plasma glucose. A 2-hour plasma glucose is when you check their blood sugar 2 hours after they have eaten. And so if that is greater than 200, then that's considered diabetic. And then a random plasma glucose is you can check it at any time. There's no, so they could have eaten an hour ago or whatever. A random is just random throughout the day, and that should not be greater than 200 either, and that could be indicative of diabetes. So a couple complications of diabetes, which we're going to talk about, is hypoglycemia. Hypo, remember when I said something is hypo, that means low. So hypoglycemia, low blood sugar. And then remember when I talked about something that's hyper, that's excessive. So high blood sugar is hyperglycemia. And so you have two types of complications with hyperglycemia, which we will discuss here. Hyperglycemic, hyperosmolar, nonketotic syndrome, or you might see it as HHNKS. This happens with our type 2 diabetes, and then diabetic ketoacidosis happens with our type 1 diabetics. And so we're going to talk about each of these symptoms or conditions here shortly. So you've seen with the diabetics a lot of different conditions that can occur with just diabetes over time, especially if you have uncontrolled diabetes or uncontrolled blood glucose levels, and different things that can happen to patients. So when we talk about macrovascular complications, so macro means the large veins. So the large veins are affected, and so when you have macrovascular complications, you get all these conditions like heart disease and strokes and things like that. When we're talking about microvascular complications, we're talking about the smaller blood vessels that's being affected by the diabetes. So when we're talking microvascular conditions, that's conditions of the eyes and the kidneys and things like that. So when these patients we talked about possible blindness and things like that. So when the eyes start to be affected, that's microvascular complications. And then I talked about neuropathy a couple of slides back. So that's a neurologic complication of diabetes. So they get the neuropathy, and then that's the numbness, and they get the numbness and tingling. And remember, I said they can't feel their feet, when they're walking. If they get a cut or something like that, they may not be able to feel it. Okay, so hypoglycemia. So according to the American Diabetes Association, hypoglycemia can occur when the blood sugar goes below 70. So we start to get concerned. I have had patients, in the past that are 60 or below and don't show symptoms. But at the same time, if my patient is less than 70, I'm not going to take that chance and, say, oh, they're not going to be symptomatic, for a while, because hypoglycemia is considered to be under 70. So you don't want your patient to get in that danger zone, and you take action. And so we'll discuss what that action might be here shortly. But it can be caused by having too much insulin. Too much insulin is going to drop your blood sugar pretty low. Or also, we'll talk about the different types of insulins here in a couple of slides as well. But it's important for you to know the onset, peak, and duration of each of your insulins, because if you're giving your patient insulin and the insulin peaks in 30 minutes or so, and your patient's not going to eat for another hour, then that's a problem. So they could potentially become hypoglycemic if you're going to give them insulin and they're not going to eat for a while. So it's important that you know the onset, peak, and duration of your various insulins that you might be administering. So that can cause your patient to go hypoglycemic. If they skip or delay meals, so you want to make sure your meals are on time, as scheduled or whatnot. So they shouldn't be skipping or delaying meals. Unplanned strenuous activity. So anytime they're going to, exercising is good because exercising will help to lower the patient's blood sugar, but at the same time, you want to make sure it's planned, exercise, so you can have your appropriate meals or snacks, before you eat or after you eat or whatnot, so that that the blood sugar doesn't drop too low, because exercise does decrease the patient's blood glucose level. And so that's why they say exercise, is good for, diabetics, because it can help to lower, but it needs to be, planned, so that you are planning your meals appropriately as well, and your snacks as well. So some signs and symptoms of hypoglycemia. They might have a headache, impaired vision, sweating, dizziness. All these are some signs of hypoglycemia. So these are some other signs of hypoglycemia as well. Hunger. They might start shaking, irritability, anxiety, weakness, fatigue, a fast heartbeat. Fast heartbeat meaning tachycardia, are all signs and symptoms of hypoglycemia. So if you have a diabetic patient and they start experiencing these things, then you're gonna automatically think, oh, could this person be hypoglycemic? So you want to immediately, check their blood sugar and get them, something that's gonna, if indeed they are hypoglycemic, get them something that is going to, help get their blood sugar up immediately. So you want to make sure you know these signs and symptoms, because if you do have diabetic patients experiencing this, you know what to do and take action. So when we're talking about treating hypoglycemia, we need to get our patients something that's going to get their blood sugar up quickly. So if, like I said, different patients, hypoglycemia is considered a blood glucose level under 70, but different patients will start to experience different signs and symptoms at varying levels of that. So I've actually had, this is not the norm, but I've actually had a patient with a blood glucose level in her 20s. It was like 27 or something, and she was sitting there having a normal conversation with me, and didn't know, and it was just happened to be time to check her blood sugar, and she's at 27. I'm like, oh my goodness. But so different people, and then somebody else with a blood sugar of 27 could be passed out, and not coherent or conscious at that point. So if our patient is hypoglycemic and they are able to swallow, so a lot of patients would carry those glucose tablets. So if they have those glucose tablets, give them at least three of those glucose tablets to get their blood sugar up. You can get 3 of the glucose tablets. They also have the glucose gel. So if they use the glucose gel or the glucose tablets, whichever one, you can put in their mouth to, get their blood glucose level up. If you don't have those glucose tablets available, still, you got, you can get them 6 ounces of juice, some orange juice or something like that. 6 ounces of cola or something like that can help get it up. 8 ounces of 2% or skim milk would be good. 6 to 8 lifesaver candies, those little pieces of candy, 6 to 8 of those would be helpful in helping to get their blood glucose levels up. So like if we have a patient that is not able to swallow, so they're incoherent, they can't swallow, we don't want to put something in their mouth and cause them to choke or aspirate. So we have the glucagon pens that you can give IM. You just give them the glucagon pen IM, and then that'll, help get their blood glucose levels up. If they are in a hospital setting and have IV, then they may have a order for like D50W or something, IV that they can, use to help get their blood glucose levels up right away. And then, once you do this, say you give this 3 glucose tablets or whatnot, you want to recheck them again in about 15 minutes or so to, ensure that their blood glucose level is coming up. And then, provide some protein or something to help, maintain that glucose, that blood glucose level. Okay, hyperglycemic, hyperosmolar non-ketotic syndrome, HHNKS. So now this one, very important to understand that this one occurs in type 2 diabetes only, not type 1 diabetes, because with HHNKS, your body still has a small amount. Remember I said with type 2 diabetes, you still have, your body is producing some insulin, but it's not enough to meet the body's demands or meet the body's needs, or the insulin that's being produced, the cells are resistant to or something. So there's still some small amount of circulating insulin in there. So that's why this one is seen in type 2 diabetics and not type 1 diabetics. And so these people will have a extremely high blood sugar, probably over 600 when we're talking HHNKS. So it's like I said, a complication of hyperglycemia for our type 2 diabetics. So just like when we talked about diabetes, when we're talking these complications with hyperglycemia, you're going to still have those classic signs, the polydipsia, polyphagia, polyuria. So remember what each one means. Poly, when you see that word poly in front of the word, that means excessive or extreme or whatnot. So we're talking polydipsia, extreme thirst, polyuria, excessive urination, and polyphagia, extreme hunger, which is, I believe, on the next slide. Also with these patients, you'll see dry mouth, fatigue, blurred vision, weight loss, nausea, vomiting, or whatnot. And so these are additional signs and symptoms you'd see with the HHNKS, the abdominal pain, and like I said on that previous slide, polyphagia. Also with these people, you might see generalized focal seizures. And so remembering back to our neural chapters that we discussed when we talked about generalized seizures, generalized meaning affecting both sides of the brain. So obviously our treatment, because our blood sugar is so high, is going to give them some insulin to lower their blood sugar. So they'll probably be in the hospital, so they'll probably have to get some insulin through the IV, the regular insulin, likely through the IV. So we've got to get their blood sugar lowered. Is key. And then we want some IV fluids as well for to get them rehydrated again. So diabetic ketoacidosis, which is DKA, occurs in our type 1 diabetic patients. So remember, this is type 1 diabetics because there's no insulin in the body. And so since the body has no insulin at all, then it starts to break down. So it has no insulin to, which helps the glucose to get into the cells. So once the glucose gets into the cells, then it can be used for energy. But in type 1 diabetics, they have no insulin at all that it's going to help any glucose to get into those cells. So what happens is the body starts breaking down fat and protein for energy. And so when it starts breaking down that fat and protein for energy, it starts to produce the ketones. And so then your body starts to produce these ketones, causing the diabetic ketoacidosis. So some causes of diabetic ketoacidosis, obviously, if you didn't take your insulin, so your blood glucose level started to increase. Illness or infection can also cause your blood glucose, cause you to have diabetic ketoacidosis. Overeating too many carbohydrates, you're excessively eating, is going to cause your blood glucose level to go up. And severe stress that comes with like having a surgery or some type of trauma or emotional upset as well can cause diabetic ketoacidosis. So again, you see here some of these same signs and symptoms: the polydipsia, polyuria, dry mouth, fatigue, weight loss, blurred vision. You still see some of those same key signs and symptoms. But here, as we go to this next slide, you'll see some differences with diabetic ketoacidosis versus HHNKS. Okay, so when we're talking about diabetic ketoacidosis, they would have nausea, vomiting. So they'll have these Kussmaul's respirations. So Kussmaul's respirations are increased respiratory rate and depth. So increase in rate and depth of your respirations. And the body's purpose for these Kussmaul's respirations is they're trying to get rid of the acidosis that the ketones is producing. So they're trying to get rid of that acid that the ketones is producing. Remember, we said that the ketones are produced because the body is trying to break down protein and fat for energy, producing these ketones. And so these Kussmaul's respirations are trying to get rid of that acid. And so as a result of that acid, you'll have this fruity breath. You'll notice a fruity breath with these individuals with diabetic ketoacidosis. And so that's a result of the acid or acetone on the breath is what you'll notice. So and then they'll have this abdominal pain and rigidity. And so those are some key differences when we're talking about diabetic ketoacidosis versus HHNKS. The HHNKS, those individuals don't have the ketones, so they're not going to have the Kussmaul's respirations or the fruity breath. And so just remember, those are key indicators that's different between the two. So again, we got to get their blood sugar down. So insulin therapy, they'll have that, probably the IV insulin, regular insulin to get their get their blood glucose levels down. IV therapy again, electrolyte replacement as well, and education, because if they same thing, both individuals actually need the education, because if their blood glucose level went up because they didn't take their insulin, or because they're overeating, or not eating the right foods, or whatever's causing their blood glucose levels to go up like this, they need to be educated properly on how to keep a good blood glucose level. So educating them on their medications, educating them on their diet, educating them on exercise, everything that's going to help them manage their diabetes. So our type 2 diabetics, if they're will likely use oral diabetic medications. Type 1 diabetics are insulin dependent, but type 2 will be can use oral diabetics, and they can use insulin as well for type 2 as well if needed. But so we got different classifications of oral diabetic medications. So our TZD medications. So remember we said in some type 2 diabetics, the body's not sensitive to the insulin. The cells are not sensitive to the insulin or whatnot that's being produced. So you have a class of medications that can help sensitize the body to the insulin or control the hepatic suppress. So what that means is, so the liver actually, hepatic, when we're talking hepatic, we're talking liver, the liver actually can store sugar or glucose as glycogen for later use for the body to use as energy if needed. And so it can help suppress that glucose, hepatic glucose production. And so some of those type medications, you may have seen the Avandia or the Actose type medications are in that class. They can cause weight gain and edema with these medications. You don't want to use them in patients with abnormal liver function or congestive heart failure. Biguanides are another class of oral diabetic medication. So these also decrease the hepatic glucose production, but they also increase the insulin uptake, so the amount of insulin, in the circulating blood that's being, put back into the cells. So some of these medications, you may have seen it as metformin. Metformin, also called glucophage. Glucophage extended release is just the metformin hydrochloride extended release. And you should not use in these individuals with cirrhosis of the liver or any type impaired renal function as well. These patients, if they have some type of procedure that they're going to have dye injected, they're going to hold the metformin for like 1 to 2 days before their treatment. And the metformin can cause diarrhea or some type of abdominal discomfort. And like I said, all these oral diabetics are for type 2 diabetes. So that's a key indicator too, like when you're looking at your questions. If the question, say for instance, doesn't say if the patient's type 1 or type 2, if they're on an oral diabetic, it would have to be type 2 diabetes. So this is another one. So remember we said another issue could be that the insulin that's being produced is not enough to meet the body's demands or meet the needs of the body. So it's not producing enough insulin. So you have your sulfonylureas, which help stimulate the pancreas to make more insulin. So you got a whole variety of these. You've probably seen some of the more common ones. You may have seen the diabinase, the glyburide. You've probably seen glimepiride. You've probably seen glipizide or glucotrol. You've probably seen, several of those type medications. This can cause hypoglycemia and weight gain because the purpose is to, lower the blood glucose. So it can cause hypoglycemia. When we're talking about the Amaryl and the Glucotrol XL, those are extended release medications. And so whereas the other ones that are not extended release, the other ones are not extended release. And so you need to make sure those patients are eating within about 30 minutes of taking their medications. Another oral diabetic that helps to stimulate the pancreas to make more insulin are meglitinides. And so you've probably seen it as the Prandin or the Starlix. You might have seen both of those names. Again, these can cause hypoglycemia and weight gain as well. These two medications are usually out of your system within about 2 hours. Alpha glucosidase inhibitors help slow the absorption of starches. And so these are, you may have seen it as Precose or the Glycet. And so these medications do cause flatulence, which is gas, or some type of abdominal discomfort. So you don't want to give these in patients that have inflammatory bowel disease or cirrhosis. So insulin, when we're talking about insulin, remember we said our type 1 diabetics are definitely going to be using insulin. And type 2 individuals could possibly use insulin as well. But definitely our type 1s are controlled with insulin. And so your book on page 867, figure 37.2, shows various sites for insulin injections. So you have your abdomen, which is where you'll have the quickest route or quickest way the insulin is absorbed is through the abdomen. And then you have your upper arms. So you want the fatty part. So the fatty part, so the back of the arm, the fatty part of the upper arms you can inject. That would be your next quickest way for absorption. And then you have your thighs and buttocks are the areas, are also areas where you can inject the insulin, and those would be the least or the slowest absorption route for your insulin. And you want to make sure you're rotating your injection sites each time to help with the absorption of the insulin, so rotating the sites each time. And when you give your insulin, actually you should be documenting where you gave the injection site, and then that would help the next nurse to know how to appropriately rotate the injection sites as well. So different insulins, remember I talked about you need to know your peak duration and or your onset, peak, and duration of your insulins, because different insulins will have different rates in which they are the onset, the peak, and the duration will be different for each of your injection sites. Insulin is never given orally because the gastric juices would just destroy the insulin, so it's never given orally. So when we're talking about our insulin, we have short acting, rapid acting, intermediate acting, and then long acting. And so our short acting is our regular insulins. And so typically, like a lot of things can affect our blood sugar rate. So our diet, our exercise, ages, different type things can affect our need for insulin. And so that's why some of your patients you might see on a sliding scale. And so everybody's sliding scale might be different depending on, the degree of their disease process and, what the doctor has ordered or whatnot. So you need to make sure you look at that to determine what that would be. And so a lot of times the sliding scale, you might see the rapid acting, or short acting on that the sliding scale. And so it would say within this range to that range, you would give this amount of insulin if the person falls within that range. Now, say if the person has a regular dose of insulin, maybe they get 10 units automatically of the NPH. And then they could have a sliding scale on top of that, which would say if their blood sugar falls within this range, give this extra amount of the of insulin as well. And so make sure you're paying attention to which insulin you're given, because like I said, each one has a different onset, peak, and duration. So make sure, even if you pull the bottle out, make sure, even if you pull the container out and it says one thing on it, also make sure you check that bottle as well, because maybe somebody put the wrong bottle back in the container. So make sure you check the bottle and the container as well. And then I also put on Blackboard a video for you to help you see how you would mix regular and NPH, how you would mix the two. It would see clear for regular, cloudy for NPH or whatnot. And so I put a video up on Blackboard so you can see how to do that as well. We're never going to mix long-acting insulins with anything, so you're never going to mix those with anything. So like I said, our short-acting is our regular insulin. So you might have Humulin and Novolin are our regular insulins. You have rapid-acting insulin, which is Lispro or Humalog, or Lispro, as well as Novolog, or Novolog, also known as Aspart. So those are our two rapid-acting insulins. Our intermediate-acting insulins are NPH, Lint, and then Humulin and Novolin varieties. So sometimes you have insulin that's like 70-30. So it might be, part regular, part NPH mixed in there. And so so you have some of those that are intermediate acting. And then our long acting, Lantus and Levemir, are long acting insulins. And typically, I'll say typically, the long acting insulins are given at nighttime, or bedtime rather, to help sustain that individual throughout the night. And so they'll give it at night to help, sustain them. I have seen where a critical diabetic, or a brittle diabetic, I should say, a brittle diabetic that just needed that extra long acting, and I have seen them give the long acting once at bedtime and then again in the morning, because they need that extra throughout the day to help maintain them throughout the day, and they would give it at bedtime and in the morning. I've seen that a few times as well, but for the most part, most people, if they get that long acting, they'll tend to get it at bedtime for the most part. So let's get into the different types of insulin specifically. Okay, so our short-acting insulin is our Humulin and Novolin. So the onset for this insulin is about 30 minutes, and so that's when it begins to take effect. Onset, so it's at its minimum, effect. It's starting to take effect. The peak is when it's at its highest concentration, its highest point. And so that's approximately 2 to 3 hours, possibly 2 to 4 hours or so, roughly. And the duration of that insulin, it's about 3 to 6 hours, roughly, maybe 7, but about 3 to 6 roughly hours for duration. And I also put a post on Blackboard, a video on Blackboard, to kind of give you a mnemonic as to how to remember these insulins. So our rapid acting insulin is our Humalog and Novolog, and so the onset for that is less than 15 minutes. So this one is pretty quick. The peak for this, when we're talking about the humalog, is 30 minutes to 1.5 hours for the humalog, and about 1 to 3 hours for the Novolog. And then the duration for the humalog is about 2 to 6 hours, and the duration for the Novolog is about approximately 3 to 5 hours for the Novolog. So intermediate, so that's our NPH, insulin, or like the lint. The onset of the intermediate is roughly 2 to 4 hours for the onset. The peak is about between 12 to 18 hours is our peak. And then our duration is 12 to 18 hours. About 12 to 18 hours. The long-acting, that was the Lantus and Levemir. So the onset is about 1 to 2 hours for the Lantus and about 1 to 3 hours for the Levemir. There's really not a peak for your long-acting insulins. There's really no peak. And the duration for the long-acting is about 24 hours for your Lantus and about 18 to 23 hours for the Levemir. And this is just the diagram that I told you is on your book and on page 867, figure 37-2, to just kind of show you the various injection sites when you're injecting your insulin.